Good afternoon. I'm Debbie Mae Johnson, Executive Director of the Cleveland Eye Bank Foundation. Thank you so much for joining us for the third annual Virtual Vision Research Symposium to showcase the work of our local researchers and clinical scientists from our partners at Akron Children's Hospital Vision Center, Cleveland Clinic Cole Eye Institute, and University Hospitals Eye Institute. Today is National Science Day. What better day today to talk about vision research? We are so proud to support these world-class institutions through our grant funding that's aimed at improving strategies to prevent, treat, and reverse vision loss associated with eye disease in children and adults. Since 2012, the Cleveland Eye Bank Foundation has provided over $1 million in funding for local eye research. For our constituents who are attending today, thank you for your investment in the Cleveland Eye Bank Foundation. Your support makes a difference today and for future generations. We hope you are inspired today with how your gifts have impacted vision in Greater Cleveland and Northeast Ohio.
Welcome. I'm Alan Roth, President of the Board of Directors at the Cleveland Eye Bank Foundation and an ophthalmologist and corneal surgeon at Cleveland Clinic's Cole Eye Institute. On behalf of the Board of Directors, we're proud to support and bring to you today new discoveries and treatments that will have an impact in combating debilitating eye disease in the future. We would like to thank our partners at the Cleveland Foundation and Eversight for supporting today's symposium. I would also like to thank Ophthalmology Times for covering the symposium and publishing some of the presenters' research. Your interest and support helps give scientists the tools they need to discover new therapies and cures for vision loss. Enjoy the program.
Thank you, Alan. I'm Jonathan Lass. I'll be the moderator for this symposium. I'm also a member of the board of directors of the Cleveland Eye Bank Foundation. I'm an ophthalmologist, cornea specialist, and researcher at University Hospitals Eye Institute and Case Western Reserve. We're really excited to again come back this year with presenting a diverse collection of clinical and basic research from our physicians and scientists at our three partnering research institutes, both for children and adults. Before we get started, I wanted to just take a few moments to explain some of the logistics of the webinar. Your audio lines are muted to limit any background noise, and we're going to be having three panel discussions, a little different structure than the previous two symposia to try to get more interaction from our audience and from our panelists. We'll be covering Cleveland's vision children's vision issues, age-related macular degeneration and glaucoma. And there'll be a moderator for each panel with two presentations, and then the moderator will be leading a discussion and taking your questions. Feel free to send your questions through the Q&A function at the bottom of your screen. We'll be monitoring those questions. And as I said, we'll be entertaining those questions during the Q&A session after each panel. We'll try to address as many of those questions time permitting. All right, well, let's go ahead and start with our children's vision section. I'll like to introduce to you Dr. Rich Hurdle, who is the Chief of Pediatric Ophthalmology and the Children's Vision Center, and the Director of Pediatric Ophthalmology and Strabismus at Akron Children's Hospital, and he is the Robert and Jill Bernstein Chair of Ophthalmology. Rich?
Thanks, Jonathan. Hi, my name is Rich Hurdle, and it's a pleasure for me to be part of this symposium. Over the next half hour, we'll be discussing retinopathy of prematurity from two perspectives, the medical and surgical perspectives. And these will be accomplished by our two panelists, Dr. Orgay, who's a professor at Case Western Reserve University, Department of Ophthalmology and Visual Sciences. He's the William R. and Margaret E. Athens Chair and Director of the Center for Pediatric Ophthalmology and Adult Strabismus. at Rainbow Babies and Children's Hospital at University Hospital's Eye Institute. Also, Dr. Ahua, who is a current senior vitreoretinal fellow at the Cleveland Clinic Cole Eye Institute. She was a former chief resident at the University of Southern California Roski Eye Institute and graduated from undergraduate medical school at the University of Miami in Florida. I'd like to begin with Dr. Orge, but I'm not sure I see him on the panels. Farouk, are you there? I don't see Farouk on. So I was anticipating that he may be a little late. So I think what we'll do is not to wait. I think we'll switch around, and Dr. Hua is here and I think ready to speak. So let's begin with Dr. Hua, and we'll give Dr. Orge a chance to get on here. So we'll just reverse the order a little bit. Thank you, Dr. Hua.
Excellent. Can everybody hear me? All right, I'm going to take that as a yes.
Yes.
My name is Hongween Hua, and I'm currently a senior vitreoretinal surgery fellow at the Cleveland Clinic Cole Eye Institute. And I'm honored to be invited here to discuss with you the surgical management of retinopathy of prematurity. And these are my financial disclosures, none of which are relevant. So the order's a little bit switched. Primarily, the paradigm for the retinopathy of prematurity screening and treatment is such that we screen and treat so that surgery is not necessary. Screening and treatment guidelines have tremendously improved since the recognition of this disease in the 1940s. However, unfortunately, there are still instances where ROP progresses and we must surgically intervene to prevent further vision loss. I will discuss surgical indications according to the new International Classification of ROP, 3rd edition. So typically, when we reach the stage where surgery is indicated, there are two approaches to surgery for retinopathy of prematurity. One approach is to spare the lens, called lens-sparing vitrectomy, and this is typically reserved for stage 4A eyes, where there's a partial retinal detachment and the fovea, which is the center of a vision, is still attached. The second method that will approach these patients in stage 4B and 5 eyes is a surgical method in which we will take the lens, called a lensectomy, and a vitrectomy. So just to describe stage 4 and 5 eyes, in stage 4 ROP, it's defined as a partial retinal detachment. In stage 4A, the fovea, which is the center of the vision, is attached. And if you see here where my cursor is, this is the fovea, which is the center of the vision. And you can see here that outside of the fovea, outside of the macula, the retina is detached. In stage 4B eyes, the center of the vision is detached. Some features of progressive stage 4 disease include 6 or more clock hours of ridge elevation. The ridge in ROP is the area of neovascularization and traction where there's abnormal blood vessel growth. You may also see recurrent or persistent plus disease, which is defined as tortuous vessels in 2 quadrants and vitreous condensation or haze. We may also see vitreous hemorrhage or organization. And in terms of the retinal vessels, you can see acute angles of posterior retinal veins suggesting peripheral traction. So I'll discuss the surgical approach for stage 4A eyes. The goal in these eyes is to release vitreoretinal circumferential tractional components between 3 areas. The first of which is between the ridge and the anterior eye, which we can see in this plane here. The second of which is between the ridge and the peripheral retina, extending to the edge of the retina, called the ora serrata, which we can see here. And the third of which is between the ridge and the optic nerve, which is this plane right here. Importantly to note, what's not the goal of the vitrectomy in these eyes as compared to adult eyes. We do not try to completely remove all of the vitreous in these eyes because it's very adherent and gelatinous, and we do not try to completely flatten the retina. We may put air in the eye to ensure that the sclerotomy is closed and that in order to maintain the shape of the eye. And I want to point out some important work that Dr. John Sears, my mentor and the pediatric vitreoretinal surgeon at the Cleveland Clinic Cole Eye Institute, has done. In this retrospective comparative cohort study, he compared adding on a sclerobuckle, which is a silicone band that goes around the eyes, and seeing the lens-sparing vitrectomy with and without this buckle. And you can see that the outcomes in these 2 groups of patients are very similar. So we no longer add on sclerobuckles to these eyes. So here I'm going to share a surgical video showing a 4-month-old that's an X24-week male baby that had received outside laser and had advanced to a stage 4A detachment in one eye and a stage 5 detachment in the other. So this baby required bilateral eye surgery. So this is showing the lens-bearing vitrectomy for the stage 4A eye. And here there's a peritomy done where we take down the conjunctiva and we pre-place a horizontal mattress suture where the infusion cannula will be placed. A slip knot is placed to hold the infusion cannula in place. And a 25 gauge MVR blade is used to create sclerotomies without the infusion cannulas. And here we show the PVD induction, and Dr. Sears is a very talented surgeon and makes it look way easier than it is. But in these neonatal eyes, the gel or the vitreous is extremely adherent to the back of the eye. So it's a challenging skill. But when you can induce a PVD in these eyes, it's an important achievement, and it achieves the important goal of removing ridge to disc traction in these eyes. It's important. The goal of the surgery is to remove the tractional components, as I mentioned before. And you can see here that at the area of the detachment, carefully removing the vitreous and then reinforcing the area of detachment with laser. And here we're showing the closure of the eye. So it's a successful surgery. Now I'm going to discuss stage 5 ROP, which is the most advanced form. It's defined as a total retinal detachment, and the new iCrop 3 3rd edition further subdivides stage 5 detachments as A, B, and C. In stage 5A, the disc is visible, suggesting an open funnel. And in stage 5B, the disc is not visible, secondary to either a retrolental fibrovascular tissue or scarring, or a closed funnel detachment. In stage 5C, you have the components of 5B, a total retinal detachment, with more severe anterior segment abnormalities. And in both of these fundus photos, you can see that they're stage 5B with obscuration of the discs in both eyes. So here I'm going to describe the surgical approach to a stage 4B and 5. As opposed to 4A, where we spare the lens, we will take the lens, called a lensectomy, with a vitrectomy. And we do this in order to completely release anterior posterior traction, given the more advanced detachment in these eyes. So this is the other eye of the same patient that I just showed, with the limbal lensectomy and vitrectomy for stage 5 ROP. So here we've performed the peritomy again and pre-placed sutures for the infusion cannula. That keeps the eye inflated. I'm going to skip ahead here. We do a supratemporal and nasal paracentesis, and we're taking the lens here with the vitreous cutter and removing the posterior capsule. And then we move on here with PVD induction, which I mentioned is difficult, but if you can do it, is great because it removes that anterior posterior traction from the front of the eye and the back of the eye in these cases. And in this eye, you can see that the PVD induction is more difficult, but with a zoomed in view, we are able to separate that gel from the back of the eye. And here is this as an area of the 4B detachment. And you can see that there's straightening of these retinal vessels, and you can confuse the nasal and the temporal retina in these eyes because of the distortion of the anatomy from the tractional component. So here, carefully removing the gel at the area of the detachment. And again, we're going to reinforce the area of their detached retina with laser. So in this patient, at their most recent visit, they had a great outcome. The retina is attached in both eyes, and the patient is undergoing visual rehabilitation with soft contact lenses. The patient has an intermittent alternating esotropia or misalignment of the eyes, which is common in these patients. And the patient is being patched in the left eye to treat their amblyopia. Right. So the prognosis in these babies' eyes, especially when we can spare the lens in stage 4A detachments, is actually quite good. In this retrospective study, we see that the visual outcome is an average of 20/80 in these eyes, and with a high myopic refraction of -11 diopters, which has been frequently noted in the literature before. And in the seminal work of Dr. Michael Tracy, who first reported the outcomes for lens-sparing vitrectomy, we note also that the visual acuity outcome was quite good in the visual acuity that's measurable to 20/58. And this is another study looking at the visual outcome, or sorry, the anatomic outcomes of stage 5 eyes according to the new eye crop classification. And unsurprisingly, stage 5C, which is the most advanced, has the worst attachment outcomes, and the more mild stage 5A eyes do better anatomically. I'd like to thank my mentor, the pediatric vitreoretinal surgeon, Dr. Jonathan Sears, for his help in my presentation. And these are my references.
That was excellent, Dr. Hua. Fantastic. Boy, you did a great job in a small amount of time with a lot of information. And we'll have some opportunity to have some discussion after Dr. Orge gives his talk on the medical treatment. I'm looking forward to that as well. Sometimes we and the audience get a lot out of it. So I think Dr. Farouk is here and ready. And great to see you, Farouk. Glad you can make it.
Thank you all for again allowing me to be a part of this fantastic venue and putting this together one more time. And maybe I'm going to catch up with the ROP disease background a little bit more and the medical treatment aspect of this very difficult disease. And our job gets much more complicated when it comes to the surgery. So it's great that doctors like Dr. Hua is taking care of that, and as many others. So with that, with your permission, I'm going to quickly go into the ROP disease background and medical treatment. I was one of the study investigators for particularly the Regeneron aflibercept study, and I was a paid consultant for Regeneron for the aflibercept FDA approval process, as I will mention some of them, and you'll see how that's relevant as well. Back to the retinopathy of prematurity, it is a rare, but it's a vision impairing and potentially blinding retinal disease. It is still a leading cause of preventable childhood blindness worldwide. And the incidence is increasing due to improved survival of extremely premature newborns. In essence, it is to do with, as you've heard a little bit before, is an incomplete development of the peripheral retinal vascularization, which leads to ischemia and production of what we call VEGF, that promotes the abnormal vessels to grow. And then leading into, as you've heard astutely, on the potential retinal detachments. It tends to happen in babies who are less than 1,500 grams and born less than 32 weeks of gestation. And just to give you a little bit more background on how things actually do happen in the back of the eye, in the mother's womb, when everything is in a little bit better environment for the baby, the vessels do grow from the optic nerve itself, and you see the weeks of the months of gestation as here shown. In a nasal side, it's more mature. The vessels grow all the way to feed the retina around 32 to 34 weeks of gestation. And in the temporal retina, it's 38 to 40 weeks. But when the baby is born prematurely, let's say at 30, 32, or 25 weeks of gestation, we know that the vessels have not grown fully, and it stops around this red area that you're seeing. And because this is a different environment, along with the normal vessel growth, the abnormal vessels grow, and that's what we're talking about in the retinopathy of prematurity. And the retinas look somewhat like this. The red squiggly lines that you're seeing in the left side is, and I don't know if you can see my cursor right here, but where the arrow is pointing out is where the vascular or the retinal normal vessels come and stop. And on the left side, there's this avascular retina. The retina does not have the vessels. And right at that juncture, these abnormal vessels start developing. And on the right picture, this is what we call an angiography, where the dye is injected. And the white portions that you're seeing is depicting the vessels. All the areas that are lighting up is the area where the ROP, the retinopathy of prematurity, does happen. About 3 decades ago, very smart people got together to really classify on ROP, so we can talk the same language. And when you look at the ROP, it actually is specified by the zone. We'll talk about this a little bit. This depicts the location in the eye where the problem is. And we talk about staging, which gives us detail about severity, and an entity called plus disease that actually tells us that it's kind of imminently coming to a point that we need to act on before the baby goes blind. And zone 1 is where the vessels have really not much grown away from the nerve itself. And the zone 2 is an area that the vessels have grown more. And the 3, as you can see, is just the most peripheral, at least severe form. So if I have a problem in the back of my eye, zone 1 is the most severe form of the ROP. And when we talk about severity of the stages of the ROP, the first stage is right where the normal vessels come and stop, where the vessels have not grown. If there's a demarcation line, it's stage 1. And if that demarcation line is a little bit more thicker, it goes to stage 2. Then abnormal vessels start growing. That's when the stage 3 happens. And stage 4 and 5, as depicted before, is when the retina detaches. So our job is to try to prevent the patients to go into stage 4 and 5, which does require, as you've seen, extensive surgery, and the outcomes are very different. There's also an entity called plus disease, which you can see that the back of the eye vessels are very tortuous, and there is a mild, moderate, and severe form of that. In essence, when we see the plus disease, that's when we think about treatment of the eyes. There is another form called aggressive ROP. The aggressive ROP, sometimes even if the stages are not that high, but the plus disease kicks in much sooner than that because of the shunting and the aggressiveness of this disease. And this is a disease that actually can make the child go blind in days. So we watch that. The classification of the ROP guides us through many of the studies on where to do, when to do the treatment. So a prompt treatment, when we come to these criteria, as shown above, is required to avoid the retinal detachment, extensive surgery, complications, and blindness. What do we do when we decide that the baby does need the surgery or medical treatment? The standard of care recognized till recently has been laser photocoagulation therapy. And until recently, an off-label use of what we call anti-VEGF injections in the eye. And these injections, these medications stop this process and the development of the abnormal vessels. And there are many different medications that we can use. And national organizations acknowledge the off-label use and potential benefits of anti-VEGF. These have been used more than a decade, since 2008 in particular, and we're going to mention that anyhow. But one note that is recently, the aflibercept is recently approved for ROP treatment in USA, has been approved last year in Europe and Japan as well. But just go through the evolution of the ROP treatment. Initially, there was a freezing therapy called cryotherapy geared towards affecting the area that actually has the vessels have not grown into yet, which is demanding the oxygenation because it's just it cannot survive without the vessels. And that demand had been causing this, what we call the VEGF production, and then hence leading into the abnormal vessel growth. So freezing therapies have been seen. And after that quickly with the in 2003, with particularly the ET-ROP study, where the laser effect was seen, and because of the laser, it was more fine-tuned and was not causing as much as inflammation, kicked in 2003. In 2011, the BEAT-ROP study did show in a randomized fashion that the effectiveness of the anti-VEGF treatments. And again, another study in 2019, the Rainbow study, looked at another type of anti-VEGF. BEAT-ROP was looking at a medication called bevacizumab. And in 2019, the Rainbow looked at ranibizumab. And the third medication, as I mentioned, was the aflibercept. The laser photocoagulation is the standard. It's very effective, but it is unfortunately very time consuming. It takes, and we're going to talk about what the time differences are a little bit more in further slides. And there is an extensive learning curve in the laser treatment. And unfortunately, the improper administration leads to variable outcomes. So it has to be done just right. And in a very small baby, which is very difficult to handle, it's sometimes, even for an expert that actually does this, has done this for decades, could be very difficult to administer the laser treatment. Typically requires prolonged sedation, general anesthesia, and location designated for use. So you have to do the laser in a very secluded area. And so you need to transfer the child either to a facility or a different room to do this. And this all can limit access to care and or require babies to be moved, as I mentioned. So this is how it looks like. This is an extensive laser, I have to say. The laser does result in, so the area that the laser is applied, it is affecting the retina. So it does cause a peripheral vision loss. And among many other problems, high myopia is very common, and 50% of patients develop high myopia due to the treatment beyond the process. A larger portion of the retina that is requiring the laser that are needed, and particularly in more earlier disease. So if I am receiving a treatment at this stage, let's say we have a 36-week-old baby that requires this laser, the area that you're seeing in blue is the area that is would require the laser. But if it can allow the vessels to grow a little bit more and then apply the laser, then you would be able to maybe get by with lesser of a retina to be affected by the laser. And that's what we were trying to gear with different treatments as anti-VEGF. So in essence, just to visually show you the difference. So the left picture is a wide field angle of photography on a normal eye. And you can see that laser treatment at this baby did receive at 30 weeks of gestation versus at 38 weeks of gestation in the right eye. You can see much less laser needed to be performed because the normal vessels were allowed to be grown. Off-label use of anti-VEGF, again, we mentioned 2 studies. They really looked at different aspects of when we can do an effectiveness, leading into different variable other uses of these anti-VEGF treatments. Anti-VEGF is in ROP is a quick procedure. It's done generally under topical anesthesia, buys time when laser not feasible, and it actually rapidly neutralizes the VEGF and rapid effect on the aggressive posterior ROP in particular. And it's administered even with poor pupil dilation, and it could be done in bedside. So we don't have to transfer the babies for these treatments, and actually does preserve the visual field, and less high myopia has been seen by multiple studies over the years. And not only promotes the normal vasculature, but also while shrinking growth of abnormal vessels is seen. So how does it work? This is a baby that actually you can see has changes. The black arrows that you're seeing is the area that the vessels have come unstopped, and right at that ridge there's abnormal activity. And with the angiography, you can see the activity much better. The patient did receive anti-VEGF treatment, and a month later, you can see that all these white portion of these abnormal vessels have been almost erased, and you see this effect in a matter of days. And because of this trend, the anti-VEGF therapy has been increasingly used in US. One study looking at 381,000 very low birth weight infants at 819 US NICUs did show the trend of more and more anti-VEGF use due to the effect that you're seeing, and less of a laser over the decades that we have seen. Wanted to mention the aflibercept study that actually is the most recent study And it came into two different types. The first study was the Firefly, which is actually in the right side. This is comparing the aflibercept, another anti-VEGF, versus the laser therapy. This was more like a global study, and was initially done only for 26 weeks, and the effect of that was followed. Then recently, a longer follow-up in 1 year has been done. And the other the butterfly study, where the U.S. was also participated, had a longer term follow-up from the get-go. Both studies are also geared to look at 5-year results, which is underway at this point.
I'm sorry, Farouk, if you could wrap up, because we just want to have some time for questions in the panel.
Very quickly then, again, we see that with all the studies, the anti-VEGF are very compatible to the laser, and they all show about 80% of success rate. And the main differences that we do see is in the time of performing the treatment. As you can see, it takes about 10 minutes per participants versus almost 2 hours with laser. With all this, I have to say, happily, that now we have an FDA-approved treatment due to these studies, and I'll leave it at that.
Thanks, Farouk. And let's have Dr. Hua back on. I think that we've seen an evolution. I certainly have. In the over 30 years I've been taking care of babies with ROP, and we started injecting here with Avastin when I first got here in 13 years ago, and have had success with it. What I wanted to discuss with both of you was the phenomena of late recurrence after Avastin injection. And I wanted to get your impressions on both the medical and surgical treatment. The first thing I'd like to say is, I'm not sure that what this has been called is a reactivation of ROP. And from my own sense of taking care of this disease, I'm not sure it's the same physiological process as the development of ROP. It's a new disease. It's analogous when we started treating patients with HIV and AIDS with highly active antiretroviral therapy. We were getting a new process when we were on it or off it, an autoimmune disease that was separate from the actual disease or the treatment itself. So my feeling is that this neovascularization, this late process of renewed neovascularization, may be a completely different disease, particular to these babies who develop ROP and then treated and then are grown with avascular retina. This looks more like IRMA to me, that you would see in sickle cell or diabetic retinopathy. And the reason I'm bringing this up is because my concern is that it's being treated initially as a reactivation of ROP with repeat laser and repeat surgery. And I'm not sure it's been completely studied, its natural history versus its treatment. And I think we're pressured to treat. But this is the dilemma that we discuss now. And I'd like to get both of your feelings on that.
If I may, I'll give in the 2 cents on what I've seen. Actually, ROP is a continuum process. So until the vessels are fully grown in the back of the eye, or you did the laser, which actually burns away the retina that is demanding the oxygen, it just requires that follow-up, because that peripheral avascular zone is always can activate, and that's why they call it the reactivation of the disease itself. So the anti-VEGF medications stop the process and allow the vessels to grow. But unfortunately, the vessels growth is slowed down just simply because this is a different environment. And in some babies in the natural history, we do know that the peripheral avascular zone may never be developed.
That's right.
In those cases now, the ROP community is looking into if it didn't grow by 63, 64, 65 weeks of gestation, we need to go back and laser. And a lot of us actually do much earlier than that, about 55 or so. So the algorithm is to kind of see and allow the growth to be as much as possible. And when it's available, do the treatment on babies with a laser to be definitive. Now you know that they're done, and we know that patients who had received the treatment or the completion of that peripheral avascular zone has not been seen. Decades later, they have retinal problems. So now there's this big trend to prevent that to happen. So laser treatment is needed to be done. And there's more to that, but I'll leave it at that. Dr. Hua, do you have any more to add to that?
Yeah, I think you essentially said it all. Dr. Sears' favorite phrase to say is what's worse than ROP, and it's recurrent ROP. So typically our practice in these patients with a residual peripheral avascular retina is to laser these areas. But as you said before, I think it's a different disease. We don't have a lot of data on what happens long-term with these patients. And I do know of practitioners that do leave peripheral avascular retina without lasering. And I think how to manage these patients is controversial. So I think the truth of the matter is we don't know the answers yet, but to be extra conservative, our practice is to laser these areas that are not vascularized.
That's great. There was a question related to this, and I have a follow-up. So I've watched babies for many years before Avastin and before cryo, where they had avascular retinas just as a natural history of underdevelopment. They had retina without vascularization and never developed any neovascularization. So just from the natural history of naturally regressing ROP, say stage 1 or stage 2 ROP, where the retina is developed anterior to the avascular ridge and never developed any neovascularization. So at least the babies are telling us that there are some situations where avascular retina can stay avascular and not have a problem the 25 years I've seen these patients, and they have avascular retina as teenagers and adults and have never developed tears, detachments, thinning at that area. So the natural history of ROP has some babies that do have avascular retina stay that way and never need treatment. I'm not saying we shouldn't. I'm just saying that there was a question about, so should we be giving them Avastin for the rest of their lives if they don't vascularize, or should we obliterate all of the retina that doesn't have vessels, which is where we're going back and forth here.
So there are some long-term studies, and one in particular actually showed 25 years after the initial ROP phase. And actually, there's a lot of changes that we see in chronically. So as you said, if the underlying choroid can feed that peripheral avascular retina, and that's sufficient enough, it's a small area enough that it could be fed, then I don't think it changes to anything. But vast majority, unfortunately, can show thinning, the white without any, the whole spectrum from white without pressure to lattice degeneration like pictures and warping. They do have some sort of activation in 50% of the patients. But if you actually do finalize this by peripheral retinal lasers, then you stop this disease process. I think these informations are coming up as we see. The anti-VEGF has changed the dynamics because it's a one more element. But that's why I think the consensus is try to do a peripheral retina to the avascular zone so that you never see these things. I wouldn't personally leave it to chance. And it becomes very difficult to see these babies. I had a patient that actually reactivated 90 weeks of gestation. So, and it's just almost like you're wrestling with these babies to see the back of the eye.
Yeah, you got to put them to sleep, right?
They do. So it's good to kind of be done with it if you do have a very peripheral area that you tend to do the laser treatment.
So if I can summarize, it's Avastin and obliterate any avascular retina left after complete whatever the regression is going to be.
Yes, and the Avastin or the anti-VEGF treatment is only needed if you see a activation, retinal or devascularization or leakage. Hemorrhage. So that's the time the Avastin would be helpful. But the peripheral avascular zone, even if you know activation, I think needs to be lasered so that you don't have the chronic decades later disease.
Dr. Hua, do you want to finish up with something?
Yeah, our practice isn't to give these babies lifelong Avastin. It's instead to laser these areas, as Dr. Orge has mentioned.
That's great. Well, I've learned a lot today. This is really great. I like doing this in a quick time because now I have a sense of things. And I think a lot of people have a sense.
We have one question from the audience.
Sure.
Are there any studies looking into long-term effects of anti-VEGF in systemic circulation?
There are actually one of the requirements. So the FDA would only approve a medication if the medication is looked at 1 year. And there is it's not obligatory, but the pharmaceutical company needs or is willing to look at 5-year results. Because the dose of anti-VEGF treatments have been varying from person to person, practice to practice. Unless you have a particular dose that you administer all the time, then the variable of what's going on has changed. So the systemic effect has mixed messages. There are some studies actually does show that, but in vast majority seems like it's not as much seen as we think it could be, especially with the lower doses as we generally use it.
Yeah, and I think the results and interpretations of these studies can be difficult because ROP babies in general have, developmental delay and other complicated systemic issues. So I think there's a confounding issue in these studies as well.
The most recent
right.
long-term large patient population study, I think it was in pediatrics recently, showed that there was an equivalent amount of associated systemic disease in this population between those that had been injected with Avastin and those that had not. Although people are still studying to see whether Avastin affects the development or other neurologic development of lungs and kidney. But right now, there's no, at least we're not aware of any data that says that this is definitely affecting the child in any other way.
All right, well, thank you very much. There are incredible advances in ROP management over the years, and we look forward to these continued discoveries. Okay, we're going to move on to our adult group here, and a very important disease with our aging population, macular degeneration. We have two speakers, one a basic scientist and one a clinician, and our moderator will be Dr. Sunil Srivastava, who is a retina specialist and uveitis specialist at the Cleveland Clinic Cole Eye Institute. Sunil, if you could take over.
Thanks, Dr. Lass. Thanks for the introduction. What a great first section to start with. Thanks, Rich, Hungween, and Farouk. My pleasure to start on the other side, if you will, with age-related macular degeneration. I'm going to introduce for you Irina Pikalieva. She's a professor and the the vice chair for research at the Case Western Reserve Department of Ophthalmology. She's also the director of the Visual Science Research Center at Case Western Reserve University. She's going to talk to us about in a search for new therapeutics for age-related macular degeneration. Irina, take it away.
Mm-hmm. Thank you, Sunil. Okay. Can you see my screen? All right. And you can see and hear me, right?
Yes.
So, first of all, I would like to thank the Cleveland Eye Bank Foundation for support and for the opportunity to share some of our data with you. Since I'm the first speaker in the section on age-related macular degeneration, I would like to give a brief introduction on this disease. First of all, age-related macular degeneration, or AMD, is a leading cause of blindness in the elderly of industrialized countries. It's a progressive disease that destroys central vision. This is how people with AMD see the world due to changes in the macula, and macula is here. So, and this is a progressive disease, and at early AMD stage, usually you see drusen, or cholesterol-rich pale yellowish deposits. And then as disease progresses, it can go two ways. Either manifest as a dry AMD, characterized by geographic atrophy, or wet AMD, which is characterized by abnormal growth of blood vessels. And since the initial stage of disease is associated with drusen, which are full of cholesterol, my lab is focused on studies of cholesterol in the retina and brain, with the ultimate goal of finding new therapeutics for age-related macular degeneration and Alzheimer's disease. And what I'm going to do today, I'm going to show you some of our data that suggests that perhaps there is a possibility of finding a therapeutic that could treat simultaneously both diseases. Isn't that wonderful? And this compound is called efavirenz. And originally, it was developed by Bristol Myers Squibb under the brand name Sustiva. and it is approved by the FDA as an anti-HIV medication to keep the viral load low. And this is because efavirenz targets the HIV reverse transcriptase enzyme and inhibits this enzyme, thus preventing viral replication. And to HIV-positive individuals, efavirenz is given orally at a 600 milligram per day dose. It's a very large dose, and at such dose, efavirenz elicits some undesired CNS effects. But what my lab discovered, that efavirenz had unanticipated interactions with cytochrome P450-46A1, which converts cholesterol to 24-hydroxycholesterol. And this reaction initiates cholesterol elimination from the neurons in the brain and retina. And what we did at first in vitro and then in vivo in mice, we found that a small dose of this drug efavirenz allosterically activates C46A1 in the brain of a mouse model of Alzheimer's disease. And recently we completed a small pilot study showing that small dose of efavirenz also activates C46A1 in the brain of people with early Alzheimer's disease. So, but after we studied the brain of mouse model of Alzheimer's disease, we decided to look at the retina of these animals, since we never looked at these mice before. And what we found that the retina of these mice in 35% of cases has some abnormalities. And we detected these abnormalities first on in vivo imaging by ultra-high resolution spectral domain optical coherence tomography. And this how normal mouse retina looks in cross-section. And this is how mouse retina of Alzheimer's disease model looks in with pathology. And what we quickly found that this pathology is inherited pathology, and it comes from mice that we use for breeding and for obtaining these 5-FXAD mice. All right, so we looked, then we used fluorescein angiography and looked at the status of retinal blood vessels of these mice. And what we found, you don't need to be a vitreoretinal specialist to see, this is how fundus examination on fluorescein angiography looks in mice with no pathology. You don't see any leakage. And this is how you see some big fluorescein spots, leakage of fluorescein in mice with pathology. However, when we looked at mice that were treated with efavirenz, and this was for approximately a half of a year, we see that there are significant changes in how this pathology looks on SDOCT. It becomes smaller, and in terms of vascular leakage. And in terms of statistics, we see almost 7-fold increase in the frequency of these lesions, as well as leakage on fluorescein angiography. So we did a lot of investigations of the retina of these mice, and I will not show you all of our data. I will show you only some of our data. And this is the ultrastructure of the retina as shown by transmission electron microscopy. And this is how this part of the retina looks on SDOCT and on fluorescein angiography. And what we found that this structural abnormality represents subretinal deposits. And these are subretinal deposits shown by yellow arrowheads. And upon magnification, you see that it is a kind of a laminated material. We did not identify the contact of these subretinal deposits. Therefore, we cannot say that these are subretinal drusinoid deposits, which are characteristics of AMD. But what we can clearly see that upon efavirenz treatment, we see a significant decrease in the deposit size and appearance. And this is how pathology looks in the background strain. And this is how normal retina should look on a transmission electron microscopy. So since this is a model of Alzheimer's disease, of course, we did stainings for amyloid beta plaques in the brain and retina of these mice. And we used 2 stains. One which stains diffuse amyloid plaques, and the other stain, thioflavin S, which stains for dense core amyloid plaques. And you see how mouse brain is densely occupied with different types of amyloid plaques. If you look on the retina of these mice, you see essentially very, very little amyloid in the RPE Brooks membrane region in mice with no pathology, and much more amyloid beta deposition in the retina of mice with pathology. Unfortunately, we had only 3 mice that were in the treated group. Therefore, we could not do the measurements, amyloid beta measurements in the retina of treated mice, but by analogy with the brain, in which the amyloid plaque load was decreased after efavirenz treatment, we inferred and we hypothesized that we see a similar situation in the retina. Now I want to show you 2 slides with our pilot study of efavirenz in patients with early Alzheimer's disease. So the goal of this study was to find the activating C46A1 efavirenz dose, because we know that it should be smaller than 600 milligram, and we tested 2 doses. Actually, these were pediatric doses, 50 milligram and 200 milligram of efavirenz. And our major goal to see if efavirenz activates C46A1 in the brain, because its brain is a large organ and there is much more C46A1 in the brain than in the retina. And second, we wanted to see whether it's safe to give such doses of efavirenz to geriatric patients. And this is just some of our data. Our readout was the measurements of the 24-hydroxycholesterol levels, which is the product of C46A1 activities in the brain, in the plasma, because once it is formed, it goes from the brain into plasma. And what we clearly see that in every patient that received efavirenz, regardless whether it was a 50 milligram or 200 milligram efavirenz dose, we see increase in the 24-hydroxycholesterol level as compared to the baseline in all subjects. And then after we discontinued drug and let it wash out for 2 weeks, we have a decrease in the 24-hydroxycholesterol levels. So what this preclinical study of efavirenz in 5-FXAD mice suggests, that yes, perhaps indeed efavirenz should be further considered as a potential therapeutic for AMD as well as Alzheimer's disease. And with that, I would like to thank people in my lab who performed this study, as well as my collaborators, both basic science and clinicians, our NAAP30 course, and as well as Cleveland Eye Bank Foundation and other agencies that provided support for this research. And I would like to finish at that point. And yes, and I guess I will leave the questions to at the end of discussion, right?
Thank you, Irina. Great work, great stuff. I can't wait to have the discussion and ask you a couple of questions about this really fascinating work you're doing. I'm really intrigued by it. Next speaker is going to be Kat Talcott. Kat is a staff vitreoretinal surgeon at the Cleveland Clinic Cole Eye Institute. She's assistant professor of ophthalmology at the Lerner College of Medicine. She's the associate program director here at Cole Eye Institute. She's going to talk to us today about new treatments in age-related macular degeneration. Take it away, Kat.
Awesome. Thanks so much for the kind introduction. And I really enjoyed that talk on the more basic science aspects of AMD. So I'm going to be talking about new treatments clinically in terms of AMD. This is not meant to be comprehensive at all. I'm going to sort of highlight some of the sort of things that have come to market pretty recently and some of the more exciting things, but there's a lot of other things out there. All right, here are my disclosures. So I'm going to first talk about neovascular AMD. So, as we know, we are really fortunate in the retina space to have sort of multiple tools in our toolbox, or intravitreal injections that target vascular endothelial growth factor. These include approved medications as well as biosimilars now. And these medications have been really effective at improving vision in randomized clinical trial. However, myself and most of my colleagues know that unfortunately real world studies sort of illustrate that it's really hard to achieve good long-term outcomes and not the same as seen in clinical trials. And that's due to sort of issues of sort of under treatment and, getting injections for patients is a real burden, not only for them, but their caregivers, as well as us who have busy clinics. So the question sort of we're left with given this is are there options for more durable therapy or sustained delivery of anti-VEGF agents to be able to address injection burden and under treatment? One of the things that was recently approved to be able to sort of address this is port delivery system, which is a surgically implanted device designed to deliver intravitreal anti-VEGF medication in a neovascular AMD patient. It's a permanent implant that's placed at the pars plana in the operating room. And then in-clinic refill procedures can be done to make sure that there's enough medication that's there. So Susvimo is approved for the treatment of patients with neovascular AMD who have previously responded to at least 2 injections. I'm just going to show a video of sort of what this looks like, and you can see it sort of being implanted. So a sclerotomy is made in the sclera, the white tissue there, 3.5 millimeters. And then you can see underneath here that there's the choroid that's present. To decrease the chance of having vitreous hemorrhage or blood in the eye, laser is used to apply to that bed. And then a blade is used to actually make an incision to go all the way through the choroid. And then you can see the port delivery system here being placed into the sclerotomy and then carefully sort of tapped into position. It's really important these patients to make sure that conjunctiva and tenons is covering that area. Great. So, this is obviously not for everyone. It necessitates a trip to the operating room, and that's a more intense time commitment for patients, caregivers, and doctors up front. There's also an anesthesia risk, and you also need to keep seeing patients back in the clinic to check on that eye and their fellow eye. There's also a risk of endophthalmitis associated with this that's 3-fold higher than getting injections. But I think it's a nice option for some patients. Of note, there was recently some problems with the inside of the implant being dislodged. So there's a temporary recall on this. Sorry, let me go back. So another sort of technology that's been developed is looking at more durable medication. So Frisimab became available last year, and it's a bispecific antibody given via injection. That's the first to really have 2 different targets. So it targets anti-VEGF, as we're sort of used to, but also targets Ang2, which helps to stabilize vessels. And in the studies, it was shown that visual acuity gains were similar to aflibercept, which is kind of our gold standard, but much less injections were needed to be given with this medication, suggesting that it might be more durable. So another good option to have in our toolbox. I think what we all sort of want as retina specialists is sort of one-time treatment that can really treat this disease. And so gene therapy is looking after that. RGX-314 is being developed as a surgically implanted gene therapy to encode for an anti-VEGF Fab protein. Results from the phase 1/2 trial were promising. And so it's now being looked at in 2 phase 3 trials that were part of ECHOL and our large national studies. And after doing a vitrectomy, the gene therapy is actually injected into the subretinal space. So I have a video that I can show of that, of one of sort of our recent surgeries at Cole. It's really important to do a good vitrectomy in these cases to make sure that all the gel is gone. We use steroid, which is the white powder there, to make sure that the hyaloid is up to ensure that that's all removed, which we're doing. I'm just going to skip a little ahead here. It's really important to make sure there aren't any tears or breaks, but really sort of the meat of this is the injection of the gene therapy. So we use a 41 gauge cannula instrument to be able to create a bleb underneath the retina and deliver sort of the product there. This bleb is gone within a day or so post-operatively in these patients, and they're injected into the inferior retina. Great. All right, so I think that's a really promising option. Obviously, the phase 3 studies are going on, so we'll see what the results show, but I think it's great that there's sort of more longer acting therapies on the horizon. Sort of apart from neovascular AMD, geographic atrophy is an important space here. So as we know, there's really, unfortunately, have not been great treatments for geographic atrophy. And as we know, it's an advanced form of dry AMD characterized by loss of photoreceptors and RPE cells in the macula. And you can see on the exotofluorescent images that these areas of atrophy can get larger over time. And so there's different treatments sort of currently under investigation. Most of them really target complement inhibition, where activation of C3 and cleavage of C5 are implicated in inflammation associated with AMD. So activated complement can lead to inflammation and sort of cell death. So I'm going to talk about two sort of main medications that are pretty exciting. Pegcetacoplan is a complement C3 inhibitor, and this was actually recently approved about a week and a half ago. In their phase 2 study, it showed that injections every month or every other month were associated with decreased rate of growth of geographic atrophy, and that led to the phase 3 Derby and Oak study. The primary endpoint for these studies was looking at change in total area of GA lesions at 12 months, and patients either got the medication monthly or every other month. And so I can, jump ahead to here. So it in the 12-month time point, one of the studies met the endpoint, but the other one didn't. However, looking at 18 months and 24 months, both studies showed that there was significant change in the rate of growth in patients who were receiving the investigational medication. So based on that, it led to approval of Syfovre, which just got approved about 10 days ago. But I think it's important to note that, this treatment doesn't give patients back their vision and does require a lot from them, mainly in terms of injections every month or every other month. Similarly, there's another company, Iveric Bio, that has a C5 inhibitor that's being investigated, now completed GATHER1 and GATHER2 studies. And these patients, you can see in GATHER1, got pretty frequent injections. And in GATHER2, also got injections sort of every year, and their endpoint at 12 months was the same. So looking at that mean rate of growth in geographic atrophy. And in both of their phase 3 studies, it showed that the C5 inhibitor led to a decrease or less change in GA growth from baseline as compared to the sham. What's important to note, and I sort of skipped over this for Apellis, is when patients are treated with these, there's a higher risk of conversion to neovascular AMD in these patients. So then in compared to the sham. So that's something to sort of consider as well, and we have to sort of carefully monitor for. And then finally, for this indication or GA, gene therapy is also potentially on the horizon. Gyroscope has put together a complement factor I gene-based therapy that was shown to be show promising results in phase 1/2. So it's being looked at in phase 2 trials, of which we are involved with at the clinic. So here's just an example from one of our surgeries. You can see that there's atrophy in the macula in the center of the retina there. And so a vitrectomy is again done to make sure that we got out all the gel. The same cannula that we saw for the Regenix Bio medication is used similarly here. First, blebs are created using just BSS or saline first to sort of create smaller blebs to open up that subretinal space. So 2 blebs are made here, which is sort of up to the protocol of the study, whether or not how these blebs are sort of created. So 2 are created here with just BSS. And then you can see that the investigational product or the gene therapy is delivered into that bleb to make it much larger. Sometimes these blebs can be associated with changes to the tissue. So they're typically done sort of outside of the macula. Great. See, that's much bigger. Great. Good. So in conclusion, AMD, including neovascular AMD, as well as geographic atrophy, are progressive diseases that can result in sort of irreversible vision loss. So we really need effective treatments to really reduce for neovascular AMD the individual and societal burden. And this is definitely coupled with our aging population and increased prevalence of this disease. So there's many ongoing studies that are going on with potential therapeutic options. Treatments for GA were on the horizon. One recently became approved, as well as I think there's a role for this disease for potential surgical innovation in the future as well that may sort of help to deal with these burdens. Thank you so much for the opportunity to present. I really appreciate it being part of this group and look forward to our discussion.
Thank you, Kat. Great stuff. Some really intriguing stuff that on the horizon or recently on the horizon. I invite Irina to join us as well. I was actually going to start by talking to Irina first. I actually know the drug you were discussing, Sostiva, because I take care of a lot of HIV patients, and I'm curious, with your pilot study, what's the dose that you guys are using in the pilot study? Is
We
it
use-
up to 200 milligrams, or is it the
Yeah,
600
up to
milligrams?
Up to 200. No, never 600 because it inhibits. No, we should only activate 50 up to 200. I would go with 50. I would start.
You would go with 50.
Mhm.
Yeah, the one of the side effects, unfortunately, is I think within the first couple of weeks is like some neuropsychiatric side effects, and so at that high dose. So, so along those lines, I know in your mouse model you treated them for 6 months, and then saw this. Let's take this theoretically, because we're seeing treatments for dry AMD
Mhm.
that Kat showed us. If like a drug like Sostiva came out, how long or how early do you think we need to treat patients? Is it something where we're treating them at appearance at first drusen? Is this something we wait until there are, outer retinal changes? Based on, what I'm seeing from at least your preclinical data, it sounds like something we want to treat as soon as we can identify.
I would start treatment as soon as you have a medium-sized drusen to prevent formation into a large drusen.
Yeah. And, along those lines, I think, Kat, I'm going to bring it back to you, include you in this discussion, so, when we look at treating early and, you're showing us intravitreal therapy with Apellis and potentially Iveric therapies, the earlier the treatment, probably the more effect, but probably the lower risk of vision loss. How do we sell our patients on early treatment for intravitreal therapy or even systemic therapy? Is this something that you think is going to be relatively easy for us to do?
Yeah, I think unfortunately it's not going to be easy to do. I think as retina specialists, it's an interesting space we're sort of getting into because we haven't had treatment before. And so there's not much that we can do for our patients. I think, first of all, sort of we have to be able to explain to patients more why they're having trouble seeing, which I know, to be honest, I sometimes gloss over with patients because if we don't have treatment for it, we don't spend as much time there. But I think by sort of, working with them to sort of explain why they're having trouble seeing, maybe showing images, I think it's going to still be challenging, though, to commit someone to getting injections every month or every 2 months for the rest of their life if they're still going to continue to lose tissue while on the medicine. I think the frustrating thing about the studies is, although it showed that there was a slower loss of tissue if you were getting treatment, at the end of 2 years, there was no change in vision, no change in sort of quality of life metrics like reading speed. So, although it might help them with things like being able to drive for longer, live independently, and function for longer, I think it's going to be hard to sort of get people to come into clinic every month or two forever if they're, especially if they're continuing to get worse on the medicine and not better.
Yeah, we see this with ARED supplementation when we look at adherence to ARADs for people who have large drusen and risk, and probably the adherence for those who should be on it is maybe 50 to 60%, for early stage treatment. And for something like this, that's probably much more advanced where people don't see benefit. I just wonder how long patients will put up with it, to get an injection every month. I think it's exciting and great to finally have something that we can offer our patients. But I think, as you said, doesn't really restore their vision. So it's going to be a challenging sell. Do you have an ideal patient in your mind for treatment?
Yeah, I think sort of my ideal patients are, ones who have a strong family history of AMD. So they know sort of where they're headed. If they have advanced like geographic atrophy in one eye, but the other eye doesn't have center involving geographic atrophy, I think those are the patients who sort of already know probably where this could be headed, and they're desperate to do anything that they can to sort of stave that off for as long as possible. Like those are the patients who, when I talk to, want to get involved in clinical trials, and I think those are the patients who I think are going to be most motivated to get a treatment like this.
I know there are a couple of questions. I just want to ask one more to Irina. Irina, you showed us some of the pilot work. Again, the OCTs on your mouse model were, incredibly fascinating to, I know to me, and I know to Kat. We live in the space of looking at OCTs and early AMD. In your next phase of work, are you doing this? Or are you searching out for Alzheimer's patients who have drusen? What's the next phase for your work that you're doing?
So first of all, I want to recover from Alzheimer's disease trial, but then, ideally, I would like to find interested retinal specialists who would be interested to perform this study, and then, of course, to find findings. The caveat here that efavirenz should be given to people who do not take statins, because it prevents C46A1 activation. And as you all know, over 40% of people over the age of 60 in this country are on a statin. So it's very difficult to find the eligible patient. And, ideally, first of all, we need to understand what disease stage and disease type efavirenz treatment will benefit most, because it's unlikely that one drug can treat all stages of the disease. And of course, you start with the easiest when you have drusen full of cholesterol, okay?
Yeah.
Maybe to start with, and then maybe to try some patients with early neovascular AMD. I'm not sure about geographic atrophy, because here it's, it's atrophy. I don't know what can be prevented.
Sure. Yeah. Dr. Lass, I believe you had a question. Do you want to go ahead and unmute yourself, sir, and ask a question?
It's in the question.
I thought you had a question. Sorry, I apologize. Oh, so let me ask the question that's in the question box. So I think this is for Kat, but Irina, you may have an opinion on this. Do you recommend blue blocker lenses for your patients with AMD? And if so, do you have a particular brand, Kat?
I do not recommend them. Actually, the American Academy of Ophthalmology, I think, came out a couple years ago and said that they don't recommend them. So I know that there's been a lot of excitement in the last couple of years about that, but I don't recommend it. I think the big things that I drive home with my patients with AMD are, be on the AREDs and make sure that they have an AMSURGR that they're checking and that they know how to sort of get in touch with us. Because as you mentioned, we already have difficulty. It's hard for patients to sort of take medications every day and those sorts of things. So those are the things that I focus on.
Good. I'm going to switch gears and maybe talk a little bit about wet macular degeneration. Kat, you showed us. Actually, sorry, it's actually a combination, but we'll start with wet and then talk about gene therapy. So with wet macular degeneration, you showed us some new therapies. Can you go a little bit more into what happened? You mentioned PDS, so the support delivery system. We were all super excited, potentially maybe getting out to 9-month therapy. And you mentioned recall on it. So what happened, or why won't we see this being used in the near future?
Yeah, so it got approved. Everyone was very, very excited. There came with it a significant warning, as I mentioned, about endophthalmitis. And that was usually related to cases where the conjunctiva or tissue over the implant had eroded. So we sort of knew that and thought it'd be a nice option for some patients, but not for every patient. And then unfortunately, it came out that within the device itself, as you're doing the refill injection, there's a septum inside the port delivery system. And in some patients, that septum became dislodged. And so if it becomes dislodged, unfortunately, although the medication that's in there can be eluted out, you can't do any further refills on it. So the treatment would have sort of a limited sort of shelf life, and you would eventually, in order to have sort of a functional PDS again, you'd have to surgically go in and like remove it. So that was disappointing to all of us. It might be related to some of the sort of that the device wasn't able to withstand sort of normal refill procedures where you guide the needle into the device, but it was disappointing for sure. The company is working on it. It's supposed to be a temporary pause, but we'll see what happens.
Yeah. So I was going to ask both of you from a basic science point of view and a clinician point of view, as we think about gene therapy, and Kat, you showed us both potential treatments for dry AMD and wet AMD. We're really looking kind of at one target only for each, right? So we're looking at VEGF, for wet AMD, and and really complement really for dry AMD. You know, either of you can start with, I mean, maybe theoretically and then practically, you know, what's your thought on like just targeting one, maybe for dry AMD, for complement, and targeting really just only the complement pathway for a gene therapy product? Do you think that's really the way we should go at this point? And does that imply that we have to go earlier? So either way, Kat, you know, since you just started off with it, your thoughts on complement only, or should we be waiting for the gene therapy that targets multiple targets?
It'd be nice if we had gene therapy to sort of target multiple things, you know, as I've sort of learned since being in retina, the drug discovery, you know, and, you know, maturation process is just really complicated. And so, you know, as you mentioned, sort of all the options that we have are just targeting single things. And you would think that you would get sort of better results maybe by targeting sort of multiple mechanisms, but I'm sure that's much easier to say theoretically than it is to do sort of practically. I think we're all just sort of grasping for some treatment that does not require injections, you know, every 2 months or so for people's lifetime. But I think there's definitely room for improvement in the space.
Yeah, Irina, do you have an opinion on, from your point of view, of targeting complement pathway for AMD or even VEGF? Is it, you know, do you think it, as clinicians, we like to think we're unfortunately probably very downstream and very one target? You know, from your work, I mean, do you think we're going in the right direction? Is there something else we should be targeting?
I think that it should be a combination therapy that should be used, not only just targeting complement or VEGF. Yes, intravitreal injection, they're great, but perhaps something else, some other drugs that target other things that can be taken just can be taken orally. So yeah. This is, and actually this is what's going on in Alzheimer's disease field. Now approved anti-amyloid therapy, but the dogma is, okay, we will be using this, plus we need to find something else and to use a combination therapy. So I believe it's not just one drug or one type of therapy, it should be a combination.
Yeah, you know, I think, you know, it's especially if we start talking about this large population of early AMD, you know, to target, it probably has to be something systemically in order to treat both eyes, right? I can't imagine if you're 65 years old and you have medium-sized drusen, that you're getting injections in both eyes monthly for the rest of your life to reduce your risk of AMD or advancing. But, you know, it probably makes more sense for us to target it systemically. I would agree with that. I think we're at our time. Irina and Kat, thank you for a fantastic panel, and we'll pass it on to the glaucoma group.
Thank you.
Thanks for moderating.
Thank you, Sunil. A great discussion from our panelists, very promising for our aging population with macular degeneration. All right, well, we'll finish up with another disease, particularly of the aging, that is quite common and also huge advances in this area. So we're pleased to introduce Dr. Doug Rhee, who is professor and chairman at Case Western Reserve University Ophthalmology, director of the UHI Institute. He's one of the leading glaucoma specialists nationally even and internationally, and is now currently the president of the one of the largest organizations in ophthalmology here, the American Society of Cataract and Refractive Surgery. And most importantly, he's my boss. So I'll turn it over to Doug.
Thank you, Professor Last. You are the boss. So that was a very kind introduction. Well, for those audience members, thank you for sticking it through here. And in this last section, we're going to be talking about glaucoma, as Dr. Last introduced, also a condition that is much more common as we get older. And glaucoma has seen really a revolution over the last 15 years that has allowed us to have safer treatments that rival efficacy of our older treatments, but are a lot easier on the patients and safer. So we're going to hear about laser and incisional surgical advancements over the next two talks. We have Dr. Yasmin Sozeri from University Hospitals Case Western. We have Dr. Ang Lee from Cleveland Clinic Cole Eye Institute. So to start us off, talking about advances in laser therapy, Dr. Yasmin Sozeri. Dr. Sozeri, assistant professor, Case Western.
Thank you, Dr. Rhee. I'm going to go ahead and share my screen. I just want to thank the organizers of this meeting for inviting me to speak. It's been a wonderful session so far, and hopefully we can bring it home here with glaucoma. I'm going to talk about clinical trials in glaucoma and specifically talk about lasers. Laser trabeculoplasty is one of the workhorses of glaucoma, and with all of the new surgeries, it doesn't always get, I think, the credit it's due. So we're going to spend some time talking just briefly about trabecular meshwork, anatomy, and pathophysiology, trabeculoplasty, mechanism of action, and we're going to review some trials, old and new, to talk about where it's fitting into the glaucoma algorithm. So the trabecular meshwork is responsible for the majority of aqueous outflow through a pressure-dependent pathway. It's composed of 3 layers: the uveal layer, the corneoscleral layer, and the juxtacanalicular layer. These layers have trabecular cells as well as collagenous connective tissue, and there's pigment granules in there. The inner wall of Schlemm's canal also has some endothelial cells that has vacuoles that communicate with the intratrabecular spaces. When we talk about laser trabeculoplasty, there's 3 leading theories as to how it exactly is working to help lower intraocular pressure. There's the mechanical theory, which postulates that the laser causes these thermal changes that cause a contraction here and open up adjacent spaces to allow more aqueous to flow through. There's the cellular theory that postulates that the laser applied to the TM cells cause them to divide and repopulate the trabecular meshwork. And then the biochemical theory, which is what we have mostly settled on, is that the laser increases chemical mediators, which then lead to remodeling of the TM and improve aqueous outflow. I just included this slide to say that there's lots of different lasers that we use, that we can use to do trabeculoplasty. However, our kind of main laser that started it all off was the argon laser, and we refer to that as ALT. But more commonly used nowadays is the SLT, which is instead of a thermal laser, a diode laser, and so that's what most of us are using now. But there are different options available. So AEGIS, was published in the 90s, looking at ALT in the use in advanced glaucoma. And we basically had 2 treatment algorithms that they looked at for patients with advanced glaucoma. It was trabeculectomy, ALT trabeculectomy, or ALT trabeculectomy, depending on the patient's course. And they looked at results divided by race, because at the time there was some differences in outcomes that they wanted to emphasize. But basically what it came down to in the studies in the years after the original study, they found that the laser trabeculoplasty was successful at 10 years in about 50% of patients, regardless of race. The glaucoma laser trial looked at laser trabeculoplasty earlier in the disease in patients with newly diagnosed glaucoma and compared it to first-line timolol. And as you can see, the lasers who were in the medication, or the patients in the medication first arm, their pressures were about 2 points higher than the patients in the laser first arm at 2 years of follow-up. And more extended follow-up showed that the the patients who were initially treated with laser, about 40% were controlled on no or one medication, whereas only 15% of patients with the medication first were still only on one medication. There was less surgeries in the laser first arm as well. So in the 90s, we got SLT, which is, again, it's more selectively applied and to target the pigment cells in the trabecular meshwork, as opposed to those big thermal burns that we used to get with ALT. And there's been lots of studies that have compared ALT to SLT, but most of them have shown to be equivalent in lowering IOP, but less inflammation in the ALT in the SLT group and less PAS. The data on this is mixed, but I think overall there's a majority that shows less inflammation. And there's some benefit in using SLT over ALT when it comes to retreating eyes that have had previous laser. So in 2019, we got the LIGHT trial, which was sort of our modern day version of the glaucoma laser trial. It compares doing SLT to using a PGA drop as a first-line treatment for patients with primary open-angle glaucoma and ocular hypertension. It looked at patients over the course of 3 years, and it found that in the SLT group, over 90% of patients were controlled on no or one medicine, whereas only 67% of the patients in the PGA group were. Additionally, when it came to treatment escalations, disease progression, in eyes that target IOP, the SLT group was better than the PGA group. What's most remarkable is the patients in the SLT group needed less surgery, especially glaucoma surgery, in the 3 year of the study. They also looked at costs, and the patients in the SLT group on average saved 451 pounds. This was done in the UK over the course of the study. And their quality of life measures were similar. Cost is really important. This is from 2011, so the numbers may not be as up to date as they are now, but bilateral SLT is somewhere around the $675 range as the cost to the patient. In about a year's time, that's equivalent to generic latanoprost in terms of what the patient has to pay. So it's important to provide patients with effective treatments, safe treatments, but also cost-effective treatments. And so that's where SLT has been really making some strides. The SALT trial looked at perioperative anti-inflammatory drops and their effect of IOP lowering of the laser. They did find a slight improved reduction in IOP at 12 weeks post-op compared to the placebo drop. But a lot of people have criticized the study for its small sample size, small follow-up period, a short follow-up period, and the fact that by happenstance, the NSAID and the steroid group had higher pre-op IOPs compared to the placebo group, although those differences were not statistically significant. And they had more patients that underwent 360 degrees of treatment compared to the placebo group. So a lot of people, including myself, kind of take this SALT trial with a grain of salt. There have been other anti-inflammatory randomized controlled trials that did not see a difference between using steroids or NSAIDs and placebos. And they all had smaller sample sizes in the SALT trial, lower pre-op IOPs, and standardized treatments amongst the groups. So the jury's still out on that. If you think of the biochemical theory as to how SLT is working, you actually want there to be a little bit of inflammation. So I don't routinely put my patients on anti-inflammatory drops after SLT. So COAST is an exciting new trial. It's NEI-NIH funded randomized controlled trial trying to clarify the optimal interval and optimal interval and energy for SLT and repeat SLT. So it's enrolling over 635 patients, and the patients are randomized to undergo either standard dose SLT or a low dose SLT, which is about half of the dose of what the standard dose is. It's going to compare outcomes at 12 months and then re-randomize patients to either undergo SLT as needed at the original dose that they were assigned or annually with the low dose, and then they're going to look at 48-month outcomes. It's also going to delve into things like anti-inflammatory drop use so that we can better, optimize our effect of SLT. The Glorious trial is a really interesting study that's looking at a novel laser system, which will basically apply laser trabeculoplasty to 360 degrees of trabecular meshwork through the limbus without a contact lens. And doing so, it will take about 2 seconds compared to the 1.5 or 2 minutes it takes to do a full 360-degree treatment. It's still enrolling patients, and so it's still very early on, but it's an exciting way that we may be able to optimize SLT even further. So in summary, laser trabeculoplasty is a useful tool throughout the spectrum of glaucoma. It has emerging utility as a first-line therapy. I think it's safe to argue that it's disease modifying, and there are cost savings not only to the patient, but also to the healthcare system in general. You know, now some patients who are on generic latanoprost need a prior auth. So all those healthcare hours that go back and forth into getting patients their medications can kind of be expedited with laser trabeculoplasty. And we're working on the best way to apply it. And I'll save questions for later, but I just want to thank everyone again for the invitation to talk.
Thank you, Dr. Sozeri. That was a fantastic talk and very comprehensive, going over the history of laser trabeculoplasty and its current uses and current clinical questions that we're looking to solve. Dr. Lee, Assistant Professor at Lerner College of Medicine, Cleveland Clinical Eye Institute. Dr. Lee is going to be talking to us about trends in incisional surgery. So, Dr. Lee, when you're ready, please take it away.
Hi, good afternoon, everybody. It's always hard to go last following these excellent talks, so I will try my best to bring it home. I have a little bit of an ambitious talk this afternoon to try to squeeze into 10 minutes here, reviewing some of the types and evolution of glaucoma surgeries in the past few decades and looking at the volume of different types nationally and locally.
I'm sorry to interrupt. Can you go into presenter mode? We're seeing your next slide.
Let me see if I'll. There we go. Thank you for that feedback. I was wondering when the technical difficulty is going to come in today. Of course, it's me. Is that?
Yeah, that looks good. Thank you.
Okay. All right. So I wanted to start with this position paper from the American Glaucoma Society that shows the different compartments within a surgical toolkit. I know it's kind of a busy slide, and starting with the traditional glaucoma surgeries on the right-hand side, these are what we call bleb forming surgeries, which means that we are creating this water blister over the superficial layer of the eye, allowing a greater reservoir for fluid to flow and thereby decreasing eye pressure. So these are traditional trabeculectomy surgeries and tube shunts, and I'll go into a little bit of them in just a little bit. And from the minimally invasive glaucoma side, on the left-hand side, most of these surgeries are what we call non-bleb forming, with one exception of the Zen. And they address either inflow by decreasing fluid production or increasing outflow through the natural drain the patient has. So I want to draw attention to the fact that the further away we go to the right-hand side towards the bleb draining procedures, the more risk for tissue trauma, dissection, and also complications. So it's kind of a double-edged sword, so to speak. I want to take a brief historic trip to what started as a glaucoma surgical procedures. Back in the 1800s was when we realized by cutting away parts of the eye, different parts, we could reduce eye pressure and potentially decrease the chance of glaucoma progression. Back then, our understanding of glaucoma was quite simplistic. There were chronic versus acute glaucomas, and now we know that the acute glaucomas are really what we understand to be angle closure, and a lot of these are phacomorphic So it makes sense that cutting away part of the iris, as this historic graph shows, and definitely a very dramatic iridectomy at that, could help with lowering eye pressure, but also comes with plenty of complications. And even back in the 1800s, we already developed sort of the rudimentary ideas of sclerotomy, goniotomy, cyclodialysis, and cellular destruction. Without going into too much detail for each one, I just wanted to kind of give us a little backdrop on the fact that we were already understanding that surgically we have to treat glaucoma by lowering eye pressure, by increasing outflow or decreasing inflow. And in the late 1900s was when we're experimenting with different ways of perfecting the what will become the trabeculectomy surgery. And it wasn't until a couple of decades later when we have introductions of anti-scarring medicines that we're able to sustain some of these effects, because what we're creating is quite unnatural in the eye. We're essentially creating a hole with some level of filtration and hoping the eye would not scar down, which is the tissue's natural response. So we have to kind of prevent something that's quite healthy and natural. And this is what we understand to be our modern day trabeculectomy. It has a partial scleral flap guarding a full thickness entry into the eye, causing fluid to flow with a very steady, slow trickle. And the way we're able to control the slow trickle is via ways of adjustable sutures. And we're able to do this with the way that we're tying the sutures. We can release these sutures post-operatively, either by manually pulling them or by lasering them with a laser. And these techniques are what allows the trabeculectomy to be the only modifiable and titratable glaucoma surgery, even to this day. And it also allows trabeculectomy to be the most powerful glaucoma surgery we have. And still stand to kind of debate. This is our modern day gold standard, because the power it is able to have and the amount of eye pressure lowering. However, this gold standard comes with many early complications. We know it can leak, the wound can be insecure, and there can be too much filtration and too much eye pressure lowering that the entire eye collapses, causing a shallow or even flat anterior chamber. And posteriorly, from low eye pressure, the eye does not stay in shape, and it can create these elevations in the layers of the retina and the choroid, called the choroidal effusions. And the fun does not stop there, right? We all know the risk of infection following trabeculectomy is lifelong. And this is what keeps glaucoma surgeons up at night ever since you perform your first trabeculectomy. And even when pressure is low, you can have hypotony maculopathy, again, just from the eye not being able to keep shape when pressure is low. And this impacts vision significantly, and sometimes maybe to a greater degree than the underlying glaucoma that the surgery was indicated for. And also the blebs itself can be very exuberant, it can become focal and cystic, very elevated, really creating a delin or sort of this bump over the eye that causes dry eye and very severe discomfort. So there was a lot of pressure, mind the pun, to innovate even in the late 90s. This is when we were introduced with the different glaucoma implants to control some of the complications of trabeculectomy. We had the Barbelt being introduced in 1990, and then soon after the Ahmed tube shunt was introduced in 93. And this is also the decade in which we kind of refined a lot of our laser treatments as well, the ECP and CPC. And these are the lasers that control the inflow. You can think of it as sort of the eye being a faucet and sink analogy. This is the part where the faucet gets turned down a little bit, so your amount of fluid that's being produced is lowered. And later on, Dr. Cesare has had already mentioned this, but SLT was introduced later on, actually towards 2000, and ALT has already been in place, but SLT is able to reduce tissue destruction and therefore cause less complications and inflammation. And also in the late 90s is when we have introduction of a lot of eye drops as well. So we have different aqueous suppressants and prostaglandins being introduced. So overall, there is an expansion in our laser, medicine, and surgical treatment of glaucoma already in the 90s that were responding to the pressure for change following trabeculectomy. And just to kind of show you, for members of the audience who've never seen these kind of in real life, the tube shunts we're talking about are plastic implants in the eye that creates a reservoir and the stays in the eye forever, creating a surgical bleb over this implant. And the two on the left are both Ahmed valves. So these have a valve to prevent a very low eye pressure. And then the one on the right is the Barr valve, which is a larger implant, doesn't have a valve, so we have to tie off the tube initially to prevent very low eye pressure. But eventually, when there's enough healthy tissue growing over the plate and the suture naturally dissolves, then we'll be able to have a healthy amount of pressure lowering long term. So the tube shunts gained popularity very quickly. I think in the individual surgeons' hands, they're felt to be more controlled and safer. Even though they do have complications, it does seem to be a little bit more controlled than trabeculectomy, and that is indicated by the divergent trends that we're seeing in trabeculectomy versus tube shunts. So Medicare data from 1994 to 2012 shows that as trabeculectomy steadily decreased from a total volume of 50,000 range to under 20,000 in this time span, tube shunts has increased from 2,000 to 12,000. So it was kind of, going opposite directions and meeting in the middle. And locally at Kowai Institute, we have a little bit more recent data following 2011. We see that tube shunts are locally beginning to kind of plateau, reaching that final volume and staying sustained there. But trabeculectomy continues to drop. That to the present day is almost to the 50 number range. So what is accounting for this drop further below the rate of the tube shunt? What kind of surgeries are we doing instead? And this is the kind of the era and the decade of the MIGS. From 2012 to 2019, we have very quick successions and introductions of new kids on the block here. The iStent was introduced in 2012, and this is probably the poster child. It was the smallest implant in the human body and gained popularity very quickly. And we see a succession of dual blade introduced in 2015, and the CyPass, which later on was removed from market, 2016, and 2017 was Zen, 2018, Hydrus, 2019, Omni. So what are these MIGS and how do they work? There are 4 buckets in which MIGS work, and then with one being predominant, the larger bucket, and that's basically increasing outflow through the natural drain system, and that's the trabecular mesh work and the Schlem canal. And it's able to do so by 3 different ways, either by stents, by bypassing that area of resistance via an implant, or removing that tissue altogether, that's called goniotomy, or injecting viscoelastic, which is a jelly material. You can think of it kind of like a Drano, putting a little bit of pressure down that, that superficial layer of distal collector channel to lower eye pressure. And the red bucket is the suprachoroidal space, which remains kind of elusive to us. We had a brief stint with CyPass, which has been removed from market due to its concerns of corneal edema and endothelial cell count, and the iStent Super is not yet approved. In the ciliary body and the inflow, again, addressing sort of the faucet, decreasing the flow rate inside the eye, has been the ECP and CPC. And in the subconjunctival space, this is kind of bleeding into the bleb space. Some people might not even think of this as MIGS per se, because it's a little bit more towards a traditional surgery type. And we have one approved device in the US, that's the Zen. PreserFlow is not approved here.
I'm sorry, if you could wrap up so we could have a little time for questions and discussion.
Oh my goodness. Okay. So, so this is what the iStent looks like. I'll just quickly go through some of these and what they look like, and maybe for you to kind of look at the surgical video. I should be able to finish in the next 3 minutes or so. The Hydrus is what some of the actually higher level randomized clinical trials was able to show its efficacy. And you can see it's a expands 3 clock hours in the trabecular meshwork, and it's a stent that goes naturally in there. And this is in the goniotomy space where we're excising tissue. The most common blade that we use is a Kofod dual blade, and it literally looks like a little rake as you go across. And this is indicated for both with or without cataract surgery. And the GAT just really quickly has a blinking light to ensure that we're in the right space as we go around. And this creates a goniotomy as well as the visceral dilation. And it kind of threads through the entire 360 degrees. And we can, it should be just a few seconds here. And the very end, you can lasso it out, which is quite satisfying right there. Omni kind of does similar to a GAT, but gives you the option of treating otomy only inferiorly. The Zen implant, again, I'll go really quickly here just to show. This is a device that, even though it creates a bleb, is pretty well tolerated in the patient and has a very quick vision recovery. Sometimes I even do it bilaterally at the same time for patients who are progressing in both eyes. And you can see it going in right there. We do a primary needling now to prevent it from being encased in scar tissue postoperatively. I'll skip that needling part. I wanted to show, again, really briefly, so that the surgical trends we have based on IRIS registry data. Back in 2013, the predominant surgeries for the traditional surgeries, the trabeculectomy and the glaucoma tube shunts, that's the brown and navy blue. And iStent began to kind of gain momentum in the medium color blue in the very bottom here, and became the most utilized surgical procedure in glaucoma. But we do have some reimbursement reductions recently, so it'll be nice to see, it'll be interesting to see what that does to our trends. I wanted to show our local trends here at Cole. You notice that there is an uptick in our surgical volume every time there was a new MIGS that was introduced locally to Cole. And except for COVID taking a hit, we were, tremendously expanding our surgical volume here. Looking at the breakdown, again, trabeculectomy here is the navy blue, and then orange is tube shunts. That's both types of tubes. Tubes kind of stayed stable over time, but trabeculectomy has very dramatically decreased. You can see kind of definitely, I went under 100 in the 50 or even less range now. And currently goniotomy has overtaken as the most frequently performed glaucoma surgery. And with Zen and Hydrus also and GAT taking up a lot of chunk of the pie. Locally, we're not doing too much iStent recently, mainly because I think a lot of the other options are able to get greater eye pressure reduction. So I just want to conclude by saying that, this drop in trabeculectomy volume is very dramatic, and it's initially accounted for by tube shunts and more recently by mixed procedures. But the few trabeculectomies that we are doing cannot be replaced. These are, severe glaucomas with very low eye pressure that still needs like a single-digit eye pressure range. And the increase in surgical volume by mix is able to, it is accounted for by few different reasons. One is we're able to treat glaucoma much earlier, and we are able to extend the glaucoma treatment age to wider age, earlier age, and as well as more elderly patients that were previously thought were too fragile to receive surgery. And we're able to combine surgery at time of cataract surgery, sometimes even for drop burden, not necessarily for uncontrolled glaucoma. And more importantly, our comprehensive colleagues are able to do this as well. So it really allows our surgical glaucoma reach to be expanded tremendously. Thank you, and very sorry for running late there.
Fantastic job, Dr. Lee. So very comprehensive talk. One quick question for you before I move on to the full panel here. Dr. Lee, when you fractionated out the trend in iStent, did that include the iStent Classic and the iStent Inject, or is it the, yes, so just iStent Inject's not particularly popular over at Cole either. I don't think we do a ton of them.
We don't. I think they're just better options. Initially, it was very exciting when it was first introduced, but I think there are other better mix.
Very good, very good. So excellent, both of you, Dr. Zoseri, Dr. Lee. I'd like to just sort of ask first off, like a 10,000-foot view. This is more open-ended, and it's, what do you think, again, this is a comprehensive clinical as well as research talk or symposium. Dr. Zoseri, what do you think our unmet needs are in the treatment glaucoma? Let's isolate it there. We won't go into the diagnostics at this point. What's our main unmet needs?
You know, we have a, you know, I'm going to look at it glass half full. So we have a lot that we can offer patients. We have 6 different classes of medications we can use. We have laser trabeculoplasty, like I said, that targets the natural drainage system. We have incisional surgeries that are targeting the natural drainage system, as Dr. Lee went over MIGS. And we have our bypass procedures, our filtering procedures for when patients have more severe disease. I think some of the biggest challenges I have looking at my patients are patients with complex retinal history, especially patients with sclerobuckles, patients who have failed tube shunts. What do you do for them next? You know, you have second tube shunts, CBC diode, you try and squeeze a Zen in maybe somewhere. Those are my the challenging patients in my mind, that it would be nice to have more options for them.
So to summarize, it's the end stage, complicated patient where we have a lot of need yet, as well as, more, if I can paraphrase, more disease modifying treatment. So we're just getting closer and closer to interrupting the pathophysiology, but not quite there. Dr. Lee, same question from your viewpoint, from your vantage. What would you say are sort of the unmet needs in glaucoma on the therapeutic side, just the therapeutic side?
Right. We're lacking neuroregeneration, obviously. And also, I think glaucoma is a very specialized specialty. It's hard to convey to patients what we're trying to do. And what I find challenging, and the patients are finding it challenging in a different way, is that it's hard to engage them in the treatment. It's a lot of what we tell them to do, and hopefully that they have faith in what our expertise is. And it's controlling something that they don't feel. At least we hope that we catch disease before they feel it. And it's very different than the other disease processes that they experience, like high blood pressure or diabetes, in which they feel like lifestyle modification makes an immediate improvement and they can get engaged in that disease process. Whereas glaucoma is more or less, for a majority of patients, I think, a disease of bad luck, and that we kind of rely a lot on patients just plain trust in what we say. Yes, your eye pressure is high, so we need to do A, B, C so that you don't go blind. It's a very hard concept. So I think what's lacking is some kind of, maybe this is more communication wise. I get that if we could somehow engage the patient better, and it comes with also understanding of what lifestyle modifications actually do for glaucoma. I think we're kind of early on in that understanding, but there has to be something more maybe than just lowering eye pressure that we can do, that we can actively engage patients.
Yeah, no, that's a very comprehensive answer. In terms of lifestyle modification, it was interesting to see just a couple of weeks ago, they were highlighting the 2 articles that really implicated smoking for accelerated progression. And, as if we needed yet another reason not to be smoking. Right. I think we'd add that. And I just recently started including that in clinic when patients ask, is there anything else I can do? I say, you can not smoke, and they kind of roll their eyes. They're like, yeah, I never have. So, at least there is that. Dr. Zoseri and Dr. Lee, we kind of talked about, these are the procedures that you spoke about in the latter part of the MIGS procedures, Dr. Lee and Dr. Zazaria with the SLT. Seems like things are getting safer and safer. Do you think our therapy is going to evolve so that we start doing interventions sooner rather than, maybe have that paradigm switch away from medications? Let me kick it over to you, Dr. Zazaria, since you gave the laser talk.
Yeah, I think, with the light trial and the outcomes that show the difference in the need for glaucoma surgery, just even in that short 3-year follow-up, I think it's definitely becoming more and more of a first-line treatment. I offer it to everybody as a first-line treatment. I'll even offer it to patients who, they're on treatment and coming to me for the first time if they want to try as an alternative. I still think anytime we're doing something procedural, patients are hesitant, even with the safety, the high safety that, SLT has to offer. I think they're still hesitant, but I have more and more patients taking me up on it. Again, I didn't really get to talk a whole lot about this during my talk, but, generic latanoprost, I have patients that require a prior auth for that. There's so many patients have been stable for years, and now all of a sudden, I just had an email today, Betaxolol is on back order. It's, every week it's a new issue in getting them their drops. And so SLT has, I think, really kind of has a big space that it can fill. And I'm starting to use it more and more.
So Dr. Lee, if you disagree with the trend of laser, then please expand on that. But if you agree, what I might ask you then, since you gave the surgical talk, is do you think that there's a role for skipping the line and maybe doing one of our MIGS procedures before meds and lasers? Turn it over to you, Dr. Lee.
I love that question. I'm big on SLT first as well. Both of us are investigators at the COAST trial, so we believe in that. I think, and the philosophy I carry is that you really want to stretch out the mileage from the patient's natural drain as much as possible, because glaucoma is a long disease. You have a lifelong dependence on drops, and if you can somehow delay that just a little bit longer, you can potentially delay disease and also the drop burden and the quality of life burden throughout their lifetime. So I think addressing the angle, whether it's with SLT or early MIGS procedure combined with a cataract surgery, and really, I didn't address this particularly, but cataract surgery is a type of glaucoma surgery. Many of the issues we see in even what we consider open angle glaucoma may be some element of cataract encroaching on the angle a little bit and narrowing that angle. And so removing the lens, we do know in itself has efficacy. So doing early cataract surgery, goniotomy at the soonest visual significance, I think is what I would like to do. And there are patients that come in for cataract evaluation and did not know they have glaucoma. They are walking around with glaucoma and obviously never treated. And my first treatment for them would be cataract and goniotomy in that particular case, because they actually haven't come to me any earlier, but I think it works very well as a first line treatment, and sometimes they may not need drops afterwards.
So very quickly, last question. I want to kick that last part over to you, Dr. Zazaria, then I'm going to turn it over back to Dr. Last. Dr. Zazaria, do you think there's a role just over the horizon for us to be doing intervention first, surgical first?
Yeah, I think particularly in patients with angle closure, I call it like angle closure spectrum of disease. If they have high pressures or PAS formation and they have, narrow or closed angles, those patients, I think from the EAGLE trial, those patients even have cataracts, they had clear lens extractions. And so if they have glaucoma, so optic neuropathy, as well as, the high pressures, then I offer them a phaco MIGS as well. Those patients, I think it's surgery first, because you're really addressing underlying anatomical issues.
Fantastic. Thank you, Dr. Sozeri. Dr. Lee, Dr. Sozeri, fantastic talks, excellent perspectives. Thanks for answering our questions. Let me now turn it over to Dr. Lass, our moderator, bring us home.
Thank you, Dr. Ree, and thanks to both glaucoma speakers. Great session. I want to thank everyone for their contributions to today's Cleveland Eye Bank Foundation Symposium. We hope you've come away with new knowledge and the sense of excitement about the work, the vision research work being done here in Northeast Ohio and its impact really around the world. We hope to continue this type of offering and would like your feedback on this symposium and our plans for next year's symposium. Evaluation form will be mailed to you in the next several days, and there will also be a recording on the Cleveland Eye Bank Foundation website. Thanks, everyone, and have a good evening.